cervical cancer. I'm not going into the prevalence and all. I myself has worked with the HPV vaccination delivery to a particular group of community. I'll just tell the barriers which you are asking, which I faced there. First was a very high cost, which is still present in private sector. Although it was introduced by government since 2008 and 9 in Arunachal Pradesh and Gujarat, but after few, what you say, bad reporting by media, the vaccine was taken back and it was only available through prescription. But I was previously working with Employees State Insurance Corporation. So they give vaccines to their insured persons only. They purchase the vaccine, even though it has a high cost. So since it was given free to them, our students, medical students also got it free of cost. So one thing we understood, that cost is a problem. If they are given free of cost, they will take it. Secondly, urban areas, we still have a lot of middle and lower income families, lower middle income families. So until and unless it is introduced free of cost in UIP, nobody is going to buy it. We know it. Plus, our private practitioners are not very specialized in adolescent health that they can very well recommend everyone, like we are recommending for geriatrics, the influenza vaccine. And budgetary approval, yes, is needed for improving it and bringing it in UIP. But when we went with this vaccine to the community through our community medicine department, among those insured persons only, the mothers, and it was a 3-dose vaccine given for 9 to 45 years of age females. There were misconceptions among mothers also, because the decision makers are mothers most of the places, and fathers also. But mothers, they said they had misconception first, then awareness about the cancer is not there. Secondly, they are reluctant to speak about sexually transmitted infections when they come to know about it. And they have suspicion about the new vaccines, which is very prevalent in our country. And the concerns about fertilities, impacts, the side effects. But after a lot of counseling, many of them opted. But those who have already are married or having children, they were more in number to opt as compared to those who were actually for their adolescent girls, or for those who are in schools, they were not willing to get it. And even if they get the first vaccine, second and third, they were lost to follow. So that was my experience of barriers and implementation. Unless and until if it goes mandatorily in UIP, it is not easy to do it. We have models of other states, which will be discussed later on. But we are still waiting, and government has approved the budget also. We are waiting for UIP to take it up. But it is still difficult, because once the children are lost in UIP after their primary vaccinations, though catching them again in their adolescence is difficult. So I'll leave for other speakers also to come up. Then we'll discuss this much better.
Thank you, ma'am. Staying with the realm of the public health systems, how feasible is it to implement a school-based universal HPV vaccination program in India, and what role can existing public health infrastructure like ASHA and ANM workers can play in its success?
Okay, school-based, the best example of school-based implementation is Sikkim in our country, which implemented, but it did this with the help of WHO. The state health department did with WHO. The national government was not involved in it. And it was a very well micromanaged program through school. But the policies were clear, the targets were clear with the age, the vaccine implementation program, the training strategies. And the school health department, the state health department, and the district education department of the state, they collaborated. They identified a school nodal officer for this. They used WhatsApp and the conference calls at their as a platform for coordination. And further, then routine meetings and micro planning was done. Demands were raised for vaccines. Completely everything like in UIP, but one thing was added in it, that was school. The first dose was given in the school to the girls, and a lot of, but the major portion of this was advocacy and social mobilization. Until and unless you do not involve the community members, the stakeholders, the politicians, nobody comes forward. And still, and we have a lot of geographical and cultural barriers in our country. So the schools will work, but you need a lot of commitment from the people around. The parents need to be convinced by the school teachers as well as the health workers also. Like ANM and ASHA are the best in this. There are many school dropouts who were left in those programs in Sikkim also. So those have to be planned. From where will you get them? You have to take Anganwadi workers also into loop. To and ASHA workers will be doing annual survey of those adolescents who are out of school, and the this although yes, school department is also education department is overburdened, this will be one of the extra activities for them. But then if you have to achieve something like COVID, the COVID model will work in this. Everything has to be mandatory, it will work.
Thank you
Over
very
to
much.
Ishika.
Yeah, thank you very much for your answer, ma'am. That was really very insightful. Next question I have is for Dr. Ruchi Pathak. Ma'am, can you hear me? Dr. Ruchi Pathak, ma'am, can you hear me?
Hello. Yeah, sorry, I was muted.
Hello. Good evening, ma'am.
Yes, yes, I can hear you. Yeah, good evening.
Okay, so ma'am, the next question I have for you
Yeah.
is I'm given your experience in both screening and epidemiological surveillance. Which screening HPV screening methods, Pap smear, VIA, or HPV DNA testing, are most scalable in low resource areas, and how can we ensure effective follow up in community based programs?
So first of all, I thank the organizers for giving me this opportunity, and especially Ishika. A good platform to discuss with the budding young doctors. It's very pertinent topic, especially in view of WHO's guidelines 90-70-90, that 90% of the eligible population should be vaccinated. 70% of the eligible population of females should get screened by a good high performance screening test. And WHO recommends screening by HPV DNA testing. And then 90% of these screen positive women, they need to be followed up, treated, adequate treatment, be it screen positives or diagnosed cases of cancer. Now, coming to your question, that which
We can
sorry
hear
for this
you. We can
disturbance.
hear you.
Yeah, okay, okay. So now VIA is, we all know it's a very simple test. Wherein we apply freshly prepared 5% acetic acid to the cervix. We observe it for a minute and we immediately get the result. HPV DNA test is the technically most advanced objective test. And if you allow me, I can walk you through some basic advantages and disadvantages, and you all yourself will be able to understand that which is the most scalable. And when we usually talk about resource constraint settings, but we have to see the efficacy on a long-term basis. It's not only a one-time. VIA is very reasonable, no doubt, but it requires intense training. It is a subjective test. It's not reproducible. Scalability is there, but sustainability, it will again be a question. So if the organizers allow, I would like to make run few slides. Is that okay? Hello?
Ma'am,
Yeah.
yes, ma'am.
Yes, ma'am.
Ma'am,
Yes, ma'am. You can go ahead, ma'am.
Okay, thank you. Is my screen visible? Is my screen visible to you all?
Yes, ma'am, it's
yes.
visible.
Okay. So we all know about cervical cancer. We all know about, just see this slide. The cervical cancer is always develops in steps. It's not that today it's normal and tomorrow it develops into a cancer. There are 4 stages in development of cervical cancer. That is normal stage, followed by persistent HPV infection by a high-risk type, that is oncogenic types, which are around 13 or 14 in number. This HPV infection can either progress or regress. But if it progresses to pre-cancer, still we can check it by treatment, or it can itself regress. Otherwise, it may progress to cervical cancer. WHO's strategy we all know about. So if you see this diagram, you can make out that not all, this is the green line shows the percentage of HPV infection. And the purple one is the pre-cancer cases. So you can very well make out that not all infected cases develop into pre-cancer or cancer. So a very small fraction of HPV infected cases progress to cervical cancer. Now, I'm not going to discuss in detail about the virus. We all know about it, but yes, once you talk about screening tests, it is something like this. It's not that you order a French fries, it's very simple to order. You know, it's customized, specific, and you get this. It's talking about cervical cancer screening is like ordering about biryani. And if you don't know about these details, you don't know about the ingredients, if you don't know about the nuances of the technique, anyone offering the test may get confused. Why? Just see the various available options for cervical cancer. We have molecular tests, which is HPV DNA. Then there are other tests which are under evaluation. Cytologic test, pap smear is very important, which we cannot mention, which has proved its efficacy in preventing the disease in Western world. And VIA is the test which is recommended by Government of India. Now, you can see the detection range of various screening tests. VIA or VILI develops it at low-grade CIN. Pap smear a bit earlier, that is at the stage of persistent infection, when it will start bringing the change in the cervix, while HPV DNA test detects the infection itself. But the drawback is that every infection may not persist into cancer. That's why we have to be very judicious while we talk about any screening program being implemented on a large scale. Why? Because even if we have a very good resource, offering a test which detects all the infection may unnecessarily cause too much of anxiety amongst the screen positive females, and also it will increase the treatment burden of false screen positives. Pap smear sensitivity is low, though specificity is good. VIA, really, you can see that it detects late, and I've already discussed about the side effects. That it's a subjective test. Reproducibility is a problem. Now, pap smear is a cytological test. We have better version, liquid-based cytology, which overcomes the side effects of cervical conventional pap smear, but it is a costly test. So now WHO advises against implementation of pap smear in any setting which is going to start its new cervical cancer screening program, and it strongly recommends that now is the time for all the countries to transition from pap smear or VIA to HPV DNA testing. Be it low resource setting, one-time cost, unit test cost of HPV DNA is far more than VIA. But if we see the long-term benefit, then of course, HPV DNA screening is the way forward. More so when we have HPV DNA self-collecting devices, which have already proved their efficacy. You can see this is self-collection swab, wherein this can be delivered by ASHA workers or ANMs to the woman door to door. The woman can self-collect their sample. You can see this, and they can return it to ASHA workers, and which can then be brought to the centralized lab. Report can be delivered to the woman within a week, and only screen positive females need to be brought to the hospital or the treatment center for confirmation or treatment. That is, there are two strategies: screen, treat, and triage, screen, triage, and treat, or simple screen and treat approach. So both the approaches can be followed. And in view of HPV the vaccination, which is grossly going to change the landscape of cervical cancer, we need to have HPV DNA testing with extended genotyping, so that we need to understand that what type of HPV viruses are still there. Maybe we are offering HPV vaccine types which are not prevalent in that particular area. So going ahead, I think there shouldn't be any doubt that HPV DNA test is the way forward. A brief, just let's see what are the strengths and limitations of various available screening options. VIA, we know very quick result, easy to perform. It is cheaper than cytology and HPV DNA testing. Limitations, we know sensitivity is low and specificity is also, it's okay, but not as high as pap smear. It is inappropriate for older women because the STJ recedes inside the cervix. Pap smear or LBC we can discuss together because both are cytological tests. It has proved its efficacy. It has been widely used with very high specificity. The limitation is that it has long assay time, lower sensitivity, and then we don't have the type of HPV genotyping. HPV genome test advantages. It is highly sensitive, it has high specificity, self-sampling possible, and then we can do risk stratification. This is very important because we understand that which woman is in immediate need of getting treatment in compared to others, especially when we have risk constraint pertaining to the treatment. Limitations, we know it's costly, and not every infection uh, is going to develop into cancer. So I think the answer is clear that, of course, HPV DNA test in every setting is the way forward for cervical cancer. Thank you.
Thank you very much, ma'am. And following up on the practicality of such interventions, what measures should be taken not just to advocate about the vaccine, but also make sure that they're available to the masses, especially in a low resource setting like India?
Very good question, and I think previous speaker has already made my work easier. That awareness is the key, but once you go to the field, we all understand that despite so much of drive, you can see so much of awareness drive. Even the Foxy has done a lot of work in making each and every doctor, not only gynecologists, make even pediatricians. They are made available. They are made aware about the various vaccine options, but knowledge, attitude, and practice. Despite having the knowledge, there is still some barrier. The attitude is a biggest thing. Availability is not an issue nowadays, as mentioned by previous speaker. Cost is a barrier, but now we are seeing that different CSR fundings are providing free vaccination to the girls. So, and yes, inclusion in UIP is the only criteria wherein we can ensure that every eligible girl gets vaccinated. Thank you.
Thank you very much, ma'am. Now, then my co-moderator, Shashwat, will continue the session.
Uh, Thank you, Ishika. I think the insights so far have really highlighted the key point, which is that awareness is the key and how crucial public health integration is. Be it the awareness drives, as Dr. Mitasha said about the school dropouts and their need to be included in the programs, or just as ma'am highlighted, Dr. Ruchi ma'am in her well-made PPT, that HPV DNA testing in every setting should be the way to prevent. Now, moving further, my question for Dr. Sumita. Ma'am, what are the most common concerns parents raise during consultations regarding the HPV vaccine, and how do you approach counseling to address hesitancy or misinformation?
Thank you, Shashwat. Thank you, Ishika, for organizing this panel discussion. It is the need of the hour, actually. I'm sorry for the name which is coming on my screen, Dharmeen. I'm Dr. Sumita Arora, practicing in Lucknow. Actually, I have been counseling my patients, like as said by Dr. Mitasha, that it is very difficult for a private practitioner to come into contact with adolescent girls, because not many of us are dealing with adolescent population. We are dealing with sexually active population after marriage, because the majority of the patients what come to us are either suffering from some gynecological problems, or some marital problems, or some pregnancy related issues, and menopausal. So we get in touch with less number of adolescents. So first of all, I would like to tell you that you have to be proactive in counseling the elderly population who is coming to us, the sexually active population. We have to, while we are examining them for some type of problem which they have come, like for a vaginal discharge or something like that, we have to take that opportunity when we are doing an ultrasound on her, when we are doing her PS or a PV examination, then we have to take that opportunity to tell them, to make them aware that, see, you are having this problem. Have you vaccinated your girl, your child, your son or your daughter with this HPV vaccine? We have to find opportunities to catch them so that we can come to their children, and then we can tell them that adolescent vaccination for HPV is a very good thing and you should think about it. And then we can give them some literature about that HPV, and that is it, what we have to do. We do not waste much of the time. And once a patient gets convinced to get her daughter or son vaccinated for HPV, then the common concerns which come to their mind and for which we have to counsel them are that, will that vaccine which we will be giving to our kids or to our children have any side effects, some short-term side effects or some long-term side effects? So we have to tell them, no, it's absolutely safe. Minimal chances of some fever may be there, like you vaccinated your children in when they were small, so there was some painless type of vaccine. So it is a very advanced form of vaccine which has very minimal side effect, and there are no side effects. And now it has been tested in our country as well, and it has been tested for the last 50 years in Western countries also, where it is very popular from the very beginning. So we have to make them feel comfortable that there will be no side effects, because they feel that exams are coming or something like that. So we have to tell them that it is not at all a problem. For college going girls or those girls who are not in that city, we have to tell them that this vaccine is available anywhere. Like you can get the first dose today itself, do a good thing today, and after 2 months or 6 months, wherever she is, you can get the girl vaccinated there. Or if she is not exactly the hair at 2 months, then you can get it done 5 days here, 5 days there also. It will not break the schedule of your vaccination. Then they ask us that what is the relationship to periods? Can it be given during the periods day? So we have to tell them that it has no relation with their menstrual cycle. It can be given as any day, whether she is having periods or not having periods. Then they tell us that we have come for some fever for the daughter or for the son. So is it the right time? Can we give it when they are suffering from some other illness? So we can tell them that yes, you can give it now, but it is a very good idea that you do not insist that time, because the immunogenicity of that vaccine, the immune response of that vaccine can be a little lesser if you give the child vaccine when the son or the daughter is having fever or some other illness. So when this illness goes away, then you can tell them that you come after 6-7 days, then you take the vaccine. It is not going to cause any harm. So you can wait. Then the question is that my girl is not that type. They will not be exposed to this sexual activity. No, she goes, my driver takes the girl, or we drop the girl to school, we come back, we take the girl back from the school. So my girl is not that type. So we have to tell them that it is very common. We have to tell them that not only a sexual exposure is necessary. It has been seen that it is a horizontal transmission also, through touch also. It can spread through a examination, vaginal examination, or even a perineal examination by a gloves, of the gloves which we are wearing, can transmit. If it is not hygienic enough, it can be transmitted through a transvaginal sonography probe also. So there are chances that without even a sexual contact, the adolescent can be transmitted with this HPV vaccine, which can catch this HPV virus. So we have to ensure that whether she is exposed to sexual contact or she is not, she should get the HPV vaccination done. And we have to tell them that 9 to 15 years is an age when the potential, the immunogenic potential, you can develop more antibodies to that vaccine. And the other advantage is that you will be given only 2 vaccines. And as we all know that quadrivalent is cheaper than nanovalent. So if we are giving 2 vaccines only, then it is better to give that nanovalent, because we can afford a expensive 2 dose schedule than a non-expensive 3 dose schedule. So you can tell the advantage that this 2 dose schedule you are taking from 9 to 15, this will help you because it has a better immunogenic potential. The girl will develop more antibodies, the vaccine will be more effective. So we have to counsel them that earlier the better. Whether the girl is going for a sexual activity you do not suspect, even then she needs a vaccination. Some parents feel that vaccination can be endorsing or encouraging sexual activity in their children, but you have to get this concept out of their mind that today the society is such that telling your children that you have given this HPV vaccination is not endorsing the sexual activity, not encouraging them to go ahead with the sexual activity, but this is just taking care of them. And you have to tell them that without sexual activity also, it is transmitting. So it is very important that you counsel them, you give 2 minutes or 5 minutes to them and take out all these doubts from their mind so that they feel encouraged to get the vaccination as early as possible. Less than 15th birthday if they take, then there is advantage that the immunogenicity of that vaccine will be better and better antibodies will form and they can have a better advantage of this.
Thank you, ma'am. That was very insightful. And speaking from your surgical experience, could you share how vaccination has impacted the clinical burden of HPV related conditions like CIN and cervical carcinoma, particularly in women with delayed screening?
See, we are working in a country where vaccination is not um, very much prevalent for HPV nowadays. But 2% of the population is only covered with HPV vaccine. And out of that, 95% are women, 5% only are men. So we, as far as we are practicing in India, we have not seen any decline, too much decline in the rates of cervical cancer or in CIN 2 and 3. But studies have been done in countries like Australia and United Kingdom, where the vaccination started in mid 2000s. So there they have seen that there has been quite a reduction in the incidence of CIN 1, 2, and even cervical cancer, to the extent that Australia, which started vaccination as a universal UIP in 2007, have declared themselves as ward-free nation. And by 2030 or 35, they are predicting that they will be cervical cancer free society. So preliminary reports and preliminary studies have shown that this really has a very good impact. And as said, that the model of COVID which was there those days will help a lot in spreading this knowledge in India, in awareness in India, that it is very linking things to your Aadhaar card, bringing a celebrity like Amitabh Bachchan, Do Boon Zindagi Ki, like he did for polio and smallpox, will help a lot in mass awareness, and that certainly will help in reducing the burden of CIN 1, 2, CIS and cervical cancer in countries like India also.
Thank you, ma'am. Hopefully, the government will take notice of all these drives and will soon include it into our national
Yes,
programs.
for
Well,
that they will have to reduce the prices because that is a big hurdle.
yes, ma'am. Now, question for Dr. Saurabh, sir. Dr. Saurabh, looking at vaccination from a preventive medicine standpoint, what are the key elements of an effective HPV vaccine awareness campaign that would resonate with adolescents and parents in rural and tier 2 settings? Sir, I think you're not audible. So you're not audible to me. So you're not audible. Ishika, are you hearing, sir?
No.
Sir, I think you're not audible still.
By the time sir is able to join us, we can take the question to our next panelist.
Yeah, I think we can do that. Question for Dr. Subhi, ma'am. Dr. Rizvi, as someone deeply involved in both gynecologic practice and grassroots awareness, given your expertise in antenatal care and fetal medicine, how can obstetric consultations during early pregnancy be leveraged to initiate HPV vaccine awareness among mothers and their adolescent daughters?
Yeah. First of all, thank you so much, Ashwath and Ishika, for inviting me. Because very early, when I started my practice around 22 years back, I realized that the one of the major areas where we are lacking is awareness. And that is where I started the Heal India program called Healthy Empowered Adolescent Life, because I realized it is important to educate our adolescents as well as their parents and the society at large about the things which we are not talking about. The country which is producing the most babies is not talking about sexually transmitted diseases and the infections and how other preventable things can be worked on. So that was my basic idea, because what I get is that I got the training under NARCHI for adolescent health, because I realized that during our medical college days also, we were not talking freely about the things. And there are a lot of adolescent girls who are coming with unsafe medical abortions also from the villages to the government colleges, like which we are working. Like I was working in JNMC, and then we had those females coming who were not actually informed about many things. So that was the initial idea. And then, of course, prevention is one of the things that we need to stress on, which other developed countries are doing, and they're adopting practices for the community at the school level, the community level, and they're talking about issues which should be talked on. So that was my initial idea. And that is how, after getting training under NARCHI for adolescent health, I started these programs at different centers. So it helped me to have a community of doctors who are doing voluntary works. Like I have a cancer specialist, I have a psychiatrist, a psychologist, when we talk team. So like we are a group of friends. So instead of going for the pizza parties, we do the kind of community service. And that is how I think Dr. Ruchi knew me, and how we do. So I have been doing these cervical cancer awareness programs. And at the time when the pregnant lady comes to eye clinic, at that time only I make them aware. And many times in the early pregnancy, we can take a pap smear also. So many times there is an inhibition that if we touch the cervix, then early abortions can happen. But actually that is not happening. So if the patient is comfortable enough, because we are doing TVS also in early pregnancy, the transvaginal scan. So that is also to do the fetal viability. At the same time, when we are going for a vaginal thing, we can offer them a TVS for a early first LBC, the liquid based cytology. And the second thing is that during the antenatal period itself, I prime them about the lactational immunization, like in the postpartum period. The idea is that because this is the time that they are maximum in touch with me, like the 9 months is an enough thing, enough time for them to get primed on. At the same time, we have to, what I tell them is that I have a very crisp PPT ready with me to tell them that how the cervix is the most approachable organ, and it can be like it's a most the preventable case, like if we detect at CIN 1, 2, or 3, it's almost 100% reversible. So that is one thing that they catch on very early. And I think the receptivity increases because of the increased honest communication at the time of the antenatal visit. That was your first question, and that is there. So I believe in that, and I think a lot of like the places where we are in Gurgaon, we are actually able to take more than 90% of the cervical cancer screening, and we are able to vaccinate them also. Like today also, I screened 5 women and who could vaccinate 2. So because what, as a doctor, when we keep on giving talks also, we also become more sensitized to give them and to talk to them about this. So that is there.
Uh, Thank you, ma'am. I think we all know the age-old adage, prevention
Yeah.
is better than cure.
Yes.
And I think that's what we should all focus on here.
Yeah.
Lastly, from your perspective as a leader in women's health education, also, ma'am, from your experience in private practice and patient counseling, what role can ultrasound clinics and women health centers play in routine HPV education, especially for women who may have missed early vaccination?
Yeah, so basically, I think all the panelists have already talked about very nice things actually, and it's always a learning and experience. Any clinic can should have the responsibility of educating the persons, like the females, or in fact males also. Like all the other countries are vaccinating males also, like 9 to 15 years, because more than 50% of HPV infection is transmitted through the other partner. So that is one of the things. So be it an ultrasound clinic or a gynecology clinic, you have that opportunity to talk to them and make them understand. Especially like in my clinic, a lot of adolescents also come, and many times the patients whom I have delivered now for the last 20 years, they are coming with their adolescent kids also for vaccination. And I'm very happy for that, because all these community-based workshops and also all the online workshops which we take increases the receptivity in the society as well as in the country. And very early on, we realized that each one of us can really make a difference if we are really emotionally attached to giving time to them. Like it's a 5 minutes PowerPoint presentation. When they see it, the cervix is such an accessible thing and the vaccine is so easily available. They come forward to it and not only get themselves vaccinated, but their children also. So I guess all of us, if make a team, like the pediatricians we are with, they are also very sensitive to this issue. And in Gurgaon, most of the pediatricians are actually vaccinating the girls that are going between 9 to 15 years to them also. So I think Gurgaon is setting up a good example, and we are actually feeling very proud of the things which we do, and we are really diagnosing very early cervical cancers also. So I'm happy about that, because when we were doing PG, the cervical cancer used to be really bad at that time with all adherence to the rectum and anterior. Now we are picking it very early, and I believe that this is the beginning of the change which we are trying to make.
Thank you, ma'am. Hopefully, the change spreads throughout the country soon, and hopefully, it yields positive results as well. Now, Dr. Saurabh, sir, I think we are ready for you. Okay, sir. My first question to you is: what are the key elements of an effective HPV vaccine awareness campaign that would resonate with adolescents and parents in rural and tier 2 settings? I think I'd ask you the second question instead. What are the existing government schemes to provide in free or incentivized vaccines and optimized vaccine delivery?
He's not unmuted.
Sir, can you unmute yourself? We'll first do a sound check before you answer.
Yeah.
So you're not audible.
See if you can unmute from your end. Shashwat and Shiva.
So I think you can just type it in just if possible.
Actually, we've given him the access to unmute his mic by himself, so it is not in our hands.
So
Yes,
if I'm, maybe you
unmute
could
him.
try joining from some other device if possible.
I think he's
And
trying again to join again.
okay.
Am I audible right now?
Yes, sir. Yes, sir.
Oh
Now you're
God,
right.
I'm so
Finally,
sorry
you
about it.
are.
Yeah,
Finally.
finally. Okay, so
This is the
I'm so
only con
sorry.
with these
I'm so sorry. I
online
mean,
discussions.
I'm so sorry, everyone. Good evening, everyone, and it's been a pleasure to hear all the lovely ladies, speaking about all the aspects about HPV vaccines and vaccinations. And then, Ruchi ma'am ne to biryani aaj dikha ke literally, she kind of set my stomach on fire completely. So I think, after I'm done with this, I'm going to gorge on biryani. Anyway, so coming to your, so which question should I cater to you, Shashwat?
Sir, first question, what are the key elements of an effective HPV vaccine awareness campaign,
Okay,
sir?
so there are many aspects of key elements, as in one should be having a targeted messaging, as in it should be simple, and culturally sensitive language should not be used. And it should be focused on the cancer prevention and not the STIs, because when it comes to about as soon as you talk about the STIs, people take it as as a taboo or a stigma. They start stigmatizing. So instead of talking about the STIs, one should talk about the cancer prevention, because that would be more acceptable. And people, when they fear it, and then they get themselves vaccinated. The third one is, it should be a gender inclusive approach. We talk about HPV vaccines, and then if you go in a community and you talk about HPV vaccination, the first thing that comes into anyone's mind is, okay, fine, it is related with cervical cancer. But then people should be made aware of it, that not only the females, it should be males should also get themselves vaccinated against various cancers, as in genital warts, or the anal cancers, or the oropharyngeal cancers. And then, as Dr. Mitasha has already mentioned, the frontline workers, the grassroots workers, they are the front runners, so they should be the one, who kind of, we can utilize their existing rapport with the rural communities. So that is also one of the important aspects. And then, of course, local school teachers and community leaders, they always play a very important role, especially the Panchayati Raj, because they are the ones, who work in, the village levels, and they are the ones, who can make some really big dent in acceptance of these vaccines. Because long time, when we were doing a postgraduate, we kind of got to know that there was this. I think the speakers who hail from Lucknow, they might have I listened this news that measles vaccination caused so much of death, and after that, measles vaccination was stopped altogether. And these ashas and anganwadis, they were beaten badly, if at all they were going in the community to get their kids vaccinated for measles. So that is one of the things. And then, of course, doctors awareness mediated awareness sessions should be done, as what we are doing. Maybe the kids, the students, the adolescents who are connected here, maybe they can take a good take home message, once they go back to their houses. And then, of course, the multimedia and the based communications, like the street plays, or even the wall paintings and posters can also make a big dent in acceptance of this HPV vaccinations. And then, these Anganwadi based vaccination drive, because, the basic thing, one of the base important aspect of any vaccination to make it successful is it should be accessible. You make the vaccines, available, you make the vaccines cheap also, but then if it is not accessible, the whole purpose will go wasted. So it should be accessible, and the Anganwadi centers or even the local schools, they are accessible to everyone, and they are at least known to everyone. And anybody can go to these schools, and the vaccinations can be done easily. And of course, not even the school teachers and the anganwadis, even the parents and the adolescent, should also be engaged together, maybe in the parents teacher meeting, whenever they are going to schools, because that is where the place where, if teachers are going to tell something, or if the parents are going to listen or understand something, maybe, you know the adolescent can make a good decision then and there. Otherwise, they go back to their house and they probably might forget it. And then parents also get very skeptical. What are the issues which are related with HPV vaccinations, So this is also very important. And then, we need to address the barriers very the myths busting is very important. Like many people, they're saying that HPV vaccination can lead to infertility, or the vaccine side effects are also there. Once a side effect, they start relating that I'm going to get side effects again and again and over again, and so on and so forth. And then, as what one of the speaker has also said, yeah, if you vaccinate them early, then they start thinking that, okay, fine, my daughter is or my kid is going to have sexual activities or sexual, you know um as in resulting with the vaccination. So this is also one of the myths, which should be done. And then, of course, any vaccination should be religious and culturally acceptable. So for that, you need to engage with the local religious leader. You might have seen that, if any, preacher is going to endorse these vaccines, it is going to be more effective or more acceptable. So I think, this is, as what you have said about the effectivity of any vaccination, right?
Thank you, sir. I think that was a very well comprehensive answer covering all the aspects. My second question to you, sir, and I think it's a question which is very relevant to this whole discussion. What are the existing government schemes to provide free or incentivized vaccines and optimize vaccine delivery?
See, as of now, HPV vaccine has not been implemented in under UIP. But then, few states, the phase one of the that introduction has already been done. Sikkim, Maharashtra, and Tamil Nadu, where these vaccination has been started, as a part of UIP. But then, there are so many, recent developments have occurred, and then cost is also one of the factor. But then, thanks to this in Make in India strategy, that we have this Servavac, which is coming up, I think, which is already there. And the cost is very, very, it's very, very cheap, 200 to 300 rupees per vaccine. And, if it is going to be free of cost, definitely, it's going to be a good advantages for all of us. And then, maybe if we can leverage, or we can, kind of collate all these, you might have heard about Mission Indradhanush and intensified Mission Indradhanush. So if we can correlate, if we can just narrow down to or introduce HPV vaccination to Mission Indradhanush or intensified. So otherwise, Mission Indradhanush and these scheme is for the vaccination of for children under 2 years, right? But then, if we can correlate these, this HPV vaccination in Mission Indradhanush, it is going to solve many of the purpose. And given the fact that we are a very resource limited country, this is going to be a very effective strategy. And then, there are so many other national health programs like RKSK, Rashtriya Kishore Swasthya Karikram, which is there. And it is very, very good. And through peer education and school health days, when we celebrate, and then adolescent friendly health clinics, that is also running. And information, education, and counseling can also be done for the HPV vaccination. So this is also going to be a very important, milestone for it. And then this under school health program, which comes under Ayushman Bharat, that can also be there. And then health and wellness ambassadors are also there. These teachers are being made ambassadors, and these health and wellness messengers, like students can be made health and wellness messengers, and which can solve purpose. And this, and then of course ashas and anganwadis, we can anytime piggyback them. I know they are overburdened and really stressed about all the activities which are being running in the rural setup. Ashas and anganwadis, they are the ANMs, they are the backbones of it. So maybe we can of course, given additional incentives to ashas, for for these vaccinations, and then public-private partnerships are always there. CSRs funds are always there. And maybe you can HPV vaccinations can be done under CSR activities, and even Gavi can also go run through it. And then of course optimization of vaccine delivery infrastructure. Abhi to, so many even is there. This is effective vaccine intelligence network is there, so which ensures a very zero stockouts, and especially during the fixed day immunization drives, which is a digital platform. And now UWIN is also coming. This UWIN platform is also going under, it is under development, but soon it's going to roll down. And then, of course, the cold chain is also very strengthened. So I think, we can anytime, vaccinate, improvise these HPV vaccination under national health programs. So, and then, of course, Delhi and Punjab had already initiated school-based HPV vaccination. So if they can do it, I think why can't we? And then Sikkim is always the first Indian state, as Dr. Mitasha has already told about. So I think, by integrating with the existing structure, we can make a really big dents in HPV vaccinations.
Thank you, sir. Thank you for your answer. Now I'd like to pass it to my colleague Ashika, who take this further.
Okay, so there are a few questions we received, and these are open to all the panelists for discussion. First one is how to detect clinically CIN in very early stage as an MBBS graduate.
Liquid-based cytology is one of the things that we can actually do. Not just. Thank you. So any CIN can be detected by the liquid-based cytology. Previously, we were doing PAP screening, but now LBC is done, and I think that is quite accurate in detecting the CIN early.
The next question is how to do clinical diagnosis and examination.
So the perispeculum examination is the one thing which you visually see the cervix, and then you can see how the cervix is looking. The first is look. So if it is looking normal, then that's one of the things. If you see any erosion, or if you see the bad cervix that's there, then you can go for things like VIA, if you have got the training for VIA, which is a very simple test actually. And there's an IARC website through which you can go and see how you can prepare the 5% acetic acid, and how you can do a simple VIA. And the same way Willy also you can do. So I would request that WHO has given very nice IARC website because with which you can understand what is normal and abnormal, and how to prepare acetic acid and Lugol's iodine. That is my take on that.
Any other panelists would like to add on to something?
See, cervical biopsy is also a gold standard, for a CIN diagnosis. So it confirms and, even grades the CIN, be it grade 1, 2, and 3. I mean, if it is a mild dysplasia or a moderate dysplasia or a severe dysplasia, and then maybe a punch biopsy or a leap, but then, it
But
is a
then,
very
yeah, it is actually biopsy comes in the second way. The first thing is that you have to take the LBC. That has to be the protocol. If you see that the cervix is really bad, then you can, or even if a minutely bad or a erosion you're seeing, then you can go for the biopsy. Now, this is the stepwise approach which you have to adopt. So that is my experience.
And then, with the different age group, like if it is 21 to 29 years, you can get your pap smear done every 3 years, 3 yearlies. And
no, it is no, sir. It is yearly for the first 3 years.
Okay.
Okay, and if it is negative in these 3 years, then you have a 3 yearly done.
3 year. Okay.
Yeah,
okay.
And that is the protocol. That is the thing which we practice.
Okay.
And if we are doing HPV, then 5 yearly is
5 years. Yeah.
5 yearly HPV, then it is 5 yearly, unless and until the patient is having a clinical this thing. Though, so I always tell my patient that biology is not a very predictive. So if you are having any, for many times in Gurgaon, the partners can change. So if it is the same partner, if there is a change partner, then you can come for an early again an HPV screening again instead of waiting for 5 years.
Yeah, and I think, HIV positive women, if the women have HIV, then you
Yeah.
need to get it, every
Earlier,
1 to 2 years
yeah,
earlier. Earlier, the
Otherwise,
better.
it is 30 years. Otherwise, you can go
Yeah,
for earlier.
yeah.
That is the issue. Yeah.
Thank you, Dr. Subuhi, and thank you, Dr. Saurabh. Another question that we have is how can we spread awareness about vaccinations among different strata? Like, according to uh, how can we spread awareness basically among every strata in India?
See, awareness can be spread only by, that can be spread, as I've said, it can be spread by Asha Anganwadi because they are the frontline workers, they're the grassroots workers. If we
Yes.
talk, yeah, because if we as a doctor, we talk here in sitting in a very posh, setup, they won't be able to understand. So the first is belongingness and acceptability. So if they won't accept if any of the person from their society or their community goes and talks about it, only then they will be accepting. And then, of course, there are so many myths and taboos and stigmas, associated with vaccines because, vaccination is not very easy to be, you just go in a community and ask the person to get a urine sample, their urine sample. They are so skeptical in giving the urine samples for any test, right? So giving a vaccination, it's really a tedious task. So you need to talk about all the myths and all the side effects. And of course, side effects are there, but then you talk about the good effects of the vaccines, the advantages of the vaccines. Of course, you can take a help of any celebrities or any person, who can be a good,
Influencer.
like like a panchayati raj person, a local leader or spiritual leader. Even, if they talk about, they are going to be more acceptable in the community. And then, of course, as I've said, beneficial effect of vaccination should always be focused and stressed, and that is going to be a good point for them to accept the vaccines.
Yeah, and I see that the ICMR has got an eco model, which I presented one of the things.
Yes, yeah.
So that is like training of the healthcare providers and improving their knowledge and skill. So what we have been doing is that we have been doing in schools as well as in community centers, but we as doctors should also train and they sensitize the ANMs and increase their skill in going to the fields and talking to the patients. Like one question, one panelist, one of the audience has raised that how we can screen people who are actually not having symptoms and they only come after having symptoms. So that's a very nice question that we should always tell that by the time the symptoms come, it's already too late. So this is something, a virus that very silently sitting can be 100% treatable, like if it is caught early, and by the time your symptoms come, it can be too late. So I think eco model is one good one where they screen for breast, oral, and cervical cancer. The ICMR has been doing a good job in that.
Thank you very much, ma'am. And another question that we got was up to what age the vaccine retains its efficacy and will it be available at government level for the poorer state of the society?
Well,
Studies
there are.
till now,
Okay,
sorry.
okay. No, please, ma'am, please.
Okay, studies till now have been seen that at least 14 years they have been studied, and we have seen that the antibody level is still high. So it is said that once you vaccinate in full dosage, like 3 doses for 15 above and 2 doses for less than 15, then it is a lifetime coverage for the vaccine. So it has been seen that you do not need any more vaccination later. So maximum 14 years for that it has been studied.
Yeah. So the question was up to what age you can give. That was the question, Ishika?
Yes, ma'am. Up to what age will it be efficacious?
Up to what age? Okay, so that is answered. Like that is answered. I thought up to what age can it be given?
I mean, you can answer that as well. We'd love to know.
Yeah. So basically, it's like now 9 to 26 years. But patients who are coming late also, we tell them that we are not sure about how much efficacious it would be. But if they are willing, we can give up to 45 years too. So that is what we tell here, that the maximum activity is 9 to 26. And the earlier it is given, the better. But now it is something that is there. And of course, in all the cases when we are vaccinating, we always tell them that not to miss on their screening schedule, because they should not be under the false impression that they don't need screening. So screening has to be done as the protocol that's there, because HPV is a family of more than 100 viruses, and not all oncogenic are being protected by this thing. So that's
screening is given till 65 years of age, and
yes,
vaccination is till 45 years
yes,
of age.
yes.
But yes, vaccine cannot prevent infection. So if any
Yeah.
person who is already infected and that
Yes.
person comes up that, should I get myself vaccinated? My infection will get be gone? So
Yeah,
that
yeah.
won't be happening.
Exactly. So it's not a treatment for the
Yeah.
infection. It is just that it is going
Just
to
a
protect.
prevention.
Yeah, it's a prevention. So that is again, वो लगता है इतनी महंगी लगाई तो treat हो जाए. So we have to tell them. We have to tell them that's there. Okay, Aishika. So finally, are we going to wind up?
Yes,
Yeah, you
ma'am.
have.
Just one more thing
Yeah.
I would like to share here. Just a
Okay.
second.
So there's another question there. For patients who have undergone invasive relief for prior HPV, is there any difference in vaccination? No. The answer is no. The vaccination protocol has to be the same. There's this question from one of the audience. No?
Is my screen visible to everyone?
Yeah,
Yes.
it is.
Okay. Okay, so this is Project Suraksha that James, in collaboration with the American Association of Physicians of Indian Origin and IMC, that is Indian Medical Course for Change, they've collaborated and started Project Suraksha. And if any one of you wishes to volunteer or collaborate, you can mail on this email ID that's given. It's also mentioned in the chat section. And you can check out the website as well about what all it entails. Also, if any panelist would like to add on to anything pertaining to the topic.
No.
See, if you come up with adding, there would be a complete day, where all the speakers will start adding up to it.
Yes, we have to
So,
restrain ourselves from
Yes,
not adding.
yes.
Yeah,
but
but
then
of course.
Ishika, it's a
Yeah.
nice initiative under by you guys. I mean, Shashwat, Ishika, and Shiva, I mean, all are doing a great job in, for such kind
Exactly.
of initiative.
And we are very, very thankful to you, and keep
Yeah.
on and just shining bright. Together we can control it. Okay.
It's so good to see you all motivated for such kind of sessions,
That's
yeah.
there.
And all the speakers are so good. I mean, it's been a pleasure to see you all and listen you all and hear you all.
Same this side,
Same
sir.
here,
It was a
same here.
pleasure. Same this
Pleasure
side.
for all of us.
Thank you, sir. Thank you.
so much.
Thank you to
everyone.
all the learned panelists also. It was
Thank
nice
you so
hearing you
much.
all.
Yeah, same
Okay.
here, man. Same.
Okay. Bye-bye.
Bye-bye.
Thank you, Ishika.
Thank you.
Thanks
Thank
so
you,
much.
Thank you,
Ishika.
ma'am. Thank
Thank
you,
you, all the
everyone. Thank you,
panelists.
sir.
Thank you,
Thank
Shashu.
you, sir. Thank you, ma'am.
Thank you.
And
so
Ishika,
much.
thank your mom, Ruchi, also. She was in my college. So say thank her.
Sure.
Say Dr.